Good afternoon and welcome to the BSSH and BFIRST Carpal Injuries webinar, which is also being co-hosted by the Sri Lankan Society for Surgery of the Hand. My name is Krishan Mariathas and I will be one of your co-hosts. Please familiarise yourself with the learning objectives for the webinar. We will aim to address these objectives via a number of talks by our faculty, interspersed with short quiz and discussion sessions. I am a consultant orthopaedic hand and wrist surgeon working at the Leeds Hand Unit. I trained in the UK with fellowships in Manchester and Melbourne, Australia. I had served on the BSSH Overseas Committee for a few years, and I'm now the chair of the newly named BSSH Global Partnership Committee. My co-host is Melanie Amarasuriya, an orthopaedic hand and wrist consultant from Sri Lanka. She trained in Sri Lanka, Australia, and the UK, and is currently in the final year of her PhD in wrist biomechanics at Flinders University of South Australia. Nick Jagodinsky is an orthopaedic consultant based in North Devon. He has a subspecialist interest in complex upper limb injuries and acquired conditions of the hand, wrist, and elbow. Having completed training in the UK, he was awarded travelling fellowships to Canada and India. Nick is well published, particularly in the area of Wallant surgery, and has been a reviewer for the European Journal of Hand Surgery. He currently serves on the BSSH Global Partnership Committee. Jeremy Stanton is a consultant orthopaedic surgeon at East Suffolk and North Essex NHS Foundation Trust. He has extensive overseas experience, and as well as being a member of the BSSH Global Partnership Committee, he is also the lead for the BSSH and BFIRST webinar series as a whole. Saman Renuka is a consultant orthopaedic surgeon at Sirimavo Bandaranaike Specialised Children's Hospital, and a member of the newly formed Sri Lankan Society for Surgery of the Hand. Jonathan Jones is a consultant hand and orthopaedic surgeon in Peterborough. He trained in the UK, followed by fellowships in Derby and Melbourne, Australia. He is a current BSSH council member and has chaired the BSSH Overseas Committee. He's heavily involved in projects in Uganda and Malawi. He may not be able to join us fully today, as he's currently at the Lion Institute in Malawi, assisting in setting up their hand unit. And finally, we have Alex Vaughan, a consultant orthopaedic hand and wrist surgeon at Frimley Park in the UK. He has had extensive involvement in the BSSH Trainees Overseas Committee and has been heavily involved in running the BSSH BFIRST webinar series. This is our rough timetable for today. The quizzes and discussion sections require interaction from the audience, and we would love for you to get involved. Please, when asking questions, use the Q&A function in Zoom to post your questions. Faculty members will try and answer your question within the Q&A section or bring them up in the discussion sections. Without further ado, I will hand you over to my co-host, Melanie.
Wrist anatomy and biomechanics. This is Melanie Amarasuriya speaking. The function of the wrist is to position where the fingers want to be. While the fingers perform, the wrist facilitates the performance, coordinating the power and the precision of the human hand. In the next 15 minutes, I'll be talking about the anatomy of the wrist, which includes the carpal bones and the ligaments. With regards to the biomechanics, we will be discussing how the wrist moves and how the wrist loads. We often describe the wrist as two rows, the proximal and the distal. The long finger and the wrist tendons attach to the metacarpals and the distal carpal row. The distal row and the metacarpals function as a single unit. And the proximal row, in contrast, has no tendons attached to it. It's wedged between the distal row and the radius. We call it an intercalated segment. The lunate is at the center of this intercalated segment and behaves as the keystone of the carpus. The distal carpal row bones, the trapezium, trapezoid, capitate, hamate, are tightly bound to each other and the metacarpals with the intercarpal ligaments. And the relative movement between each of these bones are in the range of 2 to 6 degrees. But essentially, functionally, they function as a single unit. The proximal carpal row is different. The scaphoid probably is the most special bone, being susceptible to instability. It's restrained to the distal carpal row by the STT ligaments, and then at the dorsal ridge and further proximally attaches the dorsal scapholunate complex, which includes the DIC as well. But we can see that the proximal pole itself is almost bare. The moment the dorsal SL complex and the DIC is compromised or injured, the STT ligaments will start driving the scaphoid as a deforming force. Then the proximal pole becomes unstable, subluxating from the radioscaphoid facet. Lunate is a stable bone. It is well anchored to the proximal row with the scapholunate and the lunar triquetral ligaments like two arms on either side. Then like two legs, it's got long and short radiolunate ligaments, stabilizing it to the radius. Then we have the ulnar lunate ligament anchoring it to the ulna. And on the dorsal side, we have the dorsal radiocarpal ligament stabilizing it to the radius. So we can see why that the ulnar translocation of the lunate is not so common. We see ulnar translocation mostly in rheumatoid arthritis, where the ligaments are generally affected. But otherwise, in traumatic situations, ulnar translocation is not so common. Otherwise, multiple ligaments are injured. Then the triquetrum, on the other hand, is a special bone. It provides attachment for multiple ligaments that are richly innervated. Triquetrum may not play a major role in load bearing, but it's a very mobile bone carrying a confluence of these ligaments. This is important in proprioceptive function of the wrist to trigger its self-balancing mechanism. So the triquetrum is the sensory hub of the wrist. Having discussed the individual carpal bones, we'll move on to the wrist ligaments. If we only consider the osseous architecture, wrist is inherently unstable. The wrist is like 8 pebbles stacked on one another. It's unstable. So the ligaments have an enormous function to keep the wrist stable and also allowing it to be mobile. The downside, however, is there are a number of ligaments we need to know. But classifying them into functional complexes according to their location and the function makes the life a bit easier. So we have the STT ligaments, the volar radiolunate complex, ulnar carpal complex, the triquetrohamate complex, and the dorsal scapholunate triquetral complex. The function of the STT complex is to restrain the distal pole of the scaphoid to the distal row. The function of the volar radiolunate complex is to stabilize the lunate to the radius. And we've got the dorsal scapholunate triquetral complex, which consists of multiple ligaments dorsally, the DIC, scapholunate interosseous ligament, the dorsal septum, the lunar triquetral ligament. Collectively, we call it the dorsal SLT complex. If we compare this to the shoulder, we can see that the mid-carpal joint is sort of being similar to a ball and socket joint. The capitate and the hamate sits in the socket made by the proximal row. The dorsal ligament complex creates a labrum to deepen and stabilize the socket. Importantly, when the dorsal ligament complex is disrupted, where there is radiocarpal and mid-carpal joints become incongruent. And that is when we see the steps and the gaps in arthroscopy. Ulnar carpal ligament complex is the next that connects the ulna to the carpus. The ulna is the primary bone of the forearm. The radius actually rotates around the ulna at the DRUJ, with the center being the fovea. So the ulnar carpal ligaments attach to the ulnar fovea, stabilizing the triquetrum, the capitate, and the lunate. And then we have the TFCC, of course, stabilizing the DRUJ. I want to highlight 2 points outside these complexes. Number 1 is that there is no ligaments anchoring the scaphoid to the radius. The RSC ligament, the radioscaphocapitate ligament, is there connecting the radius to the capitate. But this is pretty much as like a seat belt over which scaphoid can flex and extend. There's hardly any attachment to scaphoid. So once the dorsal scapholunate complex is compromised, the scaphoid is unstable, detached from the proximal row, and subluxates, as seen in this video, as described by Watson as in scaphoid shift test. The second point is the central column. The lunate and the capitate, interestingly, has no ligamental restraints between them. And one word about the transverse carpal ligament. We do release this ligament without much of problems to human hand. But I was thinking, why is it such a thick structure? Why is it such a distinct structure there? Looking at this distal view of the carpal tunnel, I can't help but think that this is an important pulley for flexor tendons to prevent bowstringing at the wrists, especially important in climbing animals, not so much in the human wrist, I believe. Lastly, a word about nerve supply. The wrist is highly innervated by the radial nerve, the posterior introsseous nerve, the dorsal branch of the ulnar nerve. More importantly, all the ligaments with this rich innervation connect to the triquetrum. These are important for proprioception, mainly to recruit the dynamic stabilizing muscles for the wrist. In injury, these muscles act as self-balancing mechanisms of the wrist. So it's important that we respect these nerves and the ligaments that carry these nerves during our surgical approaches. On the same note, it is important to approach the wrist with minimal collateral damage. So we generally prefer arthroscopy. When we have to have an open access, we prefer the window approach described recently by Scott Wolf's team, as opposed to the conventional radial flap, which lifts off the entire complex of ligaments of the triquetrum. Let's move on to biomechanics, which includes the loading and the motion of the wrist. So I want you to imagine the wrist like a series of platforms. On the bottom, we've got the forearm, the radius and ulnar, and then the DRUJ rotating. And on top of that, we have the radiocarpal joint. On the radiocarpal joint, we've got the proximal carpal row. And on top of that, we've got the distal carpal row. Each of these platforms behave differently when the wrist is moving, and I'm going to discuss that during each movement. During flexion and extension, it's pretty much easy because in response to the long tendons, the distal row flexes, the proximal row flex with it. Both rows function in plane. Pretty simple. But in radio-ulnar deviation, it's different. In response to the long tendons, the distal row angulate or deviate radially, but the proximal row moves differently out of plane to the distal row and flexes. The scaphoid and the proximal row flexes with the radial deviation of the distal row. So the two rows move in different planes. And then the dart throwers motion is there, which is the unique special functional movement of the wrist. Now I would like you to do a dart throwers movement. First, we pronate or semi-pronate the DRHA. The proximal row remains stable, and the distal row is the one that moves. And if we build that up, we've got the radiocarpal joint, and we've got the proximal carpal row creating the mid-carpal joint. And if the proximal carpal row remains relatively stable, there is one plane along which the distal row can move. So that is indicated by the red arrow. And then that is the dart throwers plane. And if we build the distal row on top of that, this is the direction of radial extension to ulnar flexion that can occur on a stable proximal row platform. Then that is the dart throwers motion. So that is a unique and functionally important movement that coordinates the power and the precision from radial extension to ulnar flexion of the wrist. And this is coordinated by one tendon, the flexor carpi ulnaris, precisely ulnar flexing the wrist. This movement being able to throw things at rivals and enemies do offer a distinct survival advantage in evolution. So not all animals can do that. So we can see this female monkey throwing a stone at the male trying to attract attention. And the dart throwers movement does offer a survival advantage in evolution. Finally, moving on to loading. The wrist loads as columns. We know the wrist moves as rows, but it loads as columns. The radial and the central columns carry most of the load in the neutral position, so it's a shared load-bearing mechanism. But during movement, this situation changes. With the radial deviation, the radial scaphoid joint transmits more load. And when it comes to ulnar deviation, it's the radiolunate joint that transmits more load across the radiolunate facet. We can use this information to understand the normal and the abnormal wrists. These are all non-arthritic wrists. On the left, we've got the normal. On the right, we've got scapholunate instability cases. So there are different loading patterns in scapholunate instability. So rather than telling your patient that your wrist is injured, you need surgery, if we can say that your wrist is injured, it's loading abnormally, therefore you're likely to develop arthritis, and then offer surgery, I think that adds another layer of reasoning to our practice. This is where the technology is taking us to with regard to anatomy and biomechanics of the wrist. Thank you very much. And I'd like to acknowledge Professor Greg Bain, with whom I've been working for the past few years on wrist biomechanics. Thank you.
Thank you, Melanie. Now we're about to have some quiz questions, and I ask for all the audience to try and participate in them. There are no prizes. This is just for fun, but it's a nice way to test your knowledge. And don't forget, in the meantime, if you have any questions, please use the Q&A function in Zoom to put them to us, and we'll try and answer them for you. Over to you, Alex.
Okay, I'll try and launch the first quiz. Can you all see that? Yeah. Okay, so first question is, what are the tendons attached to the distal carpal row? And you've just got to click all that apply. The second question is, what are the ligaments that stabilize the lunate to the radius? And the third question is, what is the attachment site of the DIC? That's a single best answer. And the fourth question, what is incorrect about the dart thrower's motion? Tick all that apply. What we'll do is probably give you 30 seconds per question. So I think you've got about 15 seconds left. Okay, I'll stop it there. Share the results. So the correct answers for the first question were FCR and FCU. Yeah, about 60% of you got FCR and 50% got FCU, which is good. Second answer, what are the ligaments that stabilize the lunate to the radius? The correct answer is the long radiolunate, the DRC, and the short radiolunate. So most people got long radiolunate, DRC, don't forget that, only 17% of you got that, and short radiolunate, 67%. Third question, what is the single attachment site of the DIC? It's actually all of the above. Slight trick question there for Melanie. And what is incorrect about the dart thrower's motion? And the answer is during the dart thrower's motion, the proximal and the distal row move in two different planes. Okay, I'll stop that one there. And I'll hand back to Krish.
Thanks, Alex. I think in the absence of any questions from the audience, I think we'd move on to our next talk. Krishan Maridas will be delivering the next talk on wrist imaging.
Yeah.
Thanks, Krish.
This talk will focus on imaging of the carpus. These are the learning objectives we will try to address during the presentation. We have all been asked to comment on a wrist having been presented with radiographs such as these. It is vitally important that the area of interest is central to the radiograph, well exposed and covered by orthogonal views. Radiographs such as these are not adequate to comment on the wrist, as they are centered on the forearm. The appearance of the wrist here will be distorted, as it is so far away from the center of the film. Always insist on adequate radiographs. Part of our standard wrist series is the PA, or posterior anterior view. You can see that the metacarpal bases, down to the distal third of the forearm, are clearly included. Note the position the hand is in on the left. Having the fingers partially flexed lifts the carpus into a horizontal plane. If you try to rest your outstretched palm on a flat surface, you will notice that the wrist flexes forward slightly, and this will give a slightly oblique view of the carpus on your radiographs. The lateral view is 90 degrees to the PA and exposing an identical area. Lots of bones are superimposed upon one another on the lateral. It is, however, very easy to rotate slightly more or slightly less than 90 degrees compared to the PA view. In light of this, we try and standardize our lateral views to an SPC lateral. Simply put, if the pisiform lies between the volar edge of the scaphoid and the body of the capitate, then we have a true lateral. If the pisiform appears more volar than the volar edge of the scaphoid, then the radiograph is rotated. By using an SPC lateral, it is far easier and reliable to perform analysis of the lateral radiograph. In this example, we can see that the anterior margin of the scaphoid is most volar, followed by the pisiform, followed by the capitate. This is a true lateral projection of the wrist. One must be able to clearly identify the carpal bones, metacarpal bases, and distal forearm on one's radiographs. When assessing the carpus on the PA view, Gilula described 3 smooth arcs that can be drawn across the carpus of the normal wrist. The first arc is formed by the proximal surface of the proximal carpal row, seen here in green. The second arc, in yellow, runs over the distal surface of the proximal carpal row, therefore indicating the proximal articulation of the mid-carpal joint. The third arc, in red, is formed by the proximal edge of the capitate and hamate, signifying the distal side of the mid-carpal joint. The lines should all be smooth, unbroken, and not cross one another. Anything to the contrary may signify some derangement of the carpal anatomy. On the lateral projection, the metacarpals, the distal carpal row, the proximal carpal row, and the radius should all sit on top of one another. This is signified by the radial articular surface in green, the mid-carpal articular surface in yellow, and the CMC articulation in red, all being stacked on top of one another, much like bowls in your kitchen cupboard. The lateral alignment can be analysed in a little more detail by measuring the axis of the relevant bones. The metacarpal axis can be found by drawing 2 lines across the metacarpal shaft and then projecting a line that passes through the midpoint of both of these. The capitate axis is rendered by identifying the midpoint of the proximal articular surface of the capitate and the midpoint of the distal articular surface of the capitate, and then passing a line between the two. The lunate axis requires identifying the volar and dorsal lips of the lunate, and then connecting them with a line. The axis is perpendicular to this line. What you should see on the lateral radiograph of a normally aligned wrist is the metacarpal, capitate, and lunate axes all lying not only parallel to one another, but collinear. From this example, we can see that this is very close to happening. The margin of error when making measurements, as well as any slight flexion or extension of the wrist, may alter their alignment slightly, despite the lack of true pathology or instability. In this example of a radiograph of a cyclist who fell off his bike, some of us may be easily distracted by the very obvious metacarpal fractures. However, on closer inspection, we may be able to appreciate that the carpus doesn't look quite how we'd expect it to. By marking out the first arc, we can see that the line is not smooth, and there may well be a gap in the scaphoid. When marking out the second arc, we can see a clear gap and loss of curvature over the scaphoid. And when plotting the third arc, we can see that it is clearly crossing the second arc and almost the first as well. This should prompt us to look at a lateral view. This helps us to build a picture of what is happening. We can see that the bowls are no longer stacked on top of one another. The lunate is sat in the radius, but the capitate isn't on the lunate. And when plotting the axes, we can see that they are a long way from being parallel or collinear with one another. This is a trans-scaphoid perilunate injury with a couple of metacarpal fractures. It is also important to be able to plot the axis of the scaphoid. This is represented by the broken yellow line and is formed by the midpoint of the distal and proximal articular surfaces. In reality, it's very difficult to accurately place this on plane radiographs. We can use the red line as a surrogate, and this is formed by drawing a line between the most volar point of the proximal scaphoid and the most volar point of the distal scaphoid. These features are far easier to pick out on plane radiographs. And as we can see, it is parallel to the true axis. Measuring the angle between the lunate axis and the scaphoid axis is important when assessing instability. The angle should normally measure between 30 and 60 degrees. If the angle measures greater than 60 degrees, it signifies that the lunate is extended or tilted dorsally relative to the scaphoid. This is termed dorsal intercalated segment instability, or a dizzy deformity. This can be caused by either a fractured scaphoid waist displacing into flexion, or a ruptured scapholunate ligament, or the carpus adapting to a dorsally tilted radial articular surface after a distal radius fracture. If the scapholunate angle is less than 30 degrees, that signifies that the lunate is tilted too far volarly and is called a volar intercalated segment instability, or a VISI deformity. This can be due to a lunotriquetral ligament rupture or damage to the complex extrinsic ligaments that Melanie mentioned in her talk. There are occasions that special radiographic projections can be useful when assessing carpal trauma. Due to the complex shape of the scaphoid, it can be difficult to pick up irregularities with just PA and lateral views. We therefore add oblique views to try and increase our chance of spotting a minimally displaced fracture. Using 4 views rather than the standard 2 has been shown to improve sensitivity significantly. Nick will cover this in more detail in his talk. If there is a clinical suspicion of injury to the scapholunate ligament, but no obvious abnormality on the PA view, then the PA can be performed while the patient clenches their fist. This is more likely to reveal a dynamic instability as the capitate head is driven into the proximal carpal row. And if the scapholunate ligament is incompetent, it will lead to a more obvious gap between the scaphoid and the lunate. A carpal tunnel shoot-through is performed with the fingers extended and the X-ray beam tilted around 25 degrees from the vertical. This projection gives a better view of the volar side of the carpus, in particular the volar surface and ridge of the trapezium, the hook of the hamate, and the entirety of the pisiform. The complex overlapping of the carpal bones makes radiographs challenging to interpret, which is why the development of more complex imaging methods over the past few decades has dramatically improved our ability to accurately diagnose wrist pathology. The CT scan involves taking multiple radiographs in very quick succession to help build a three-dimensional picture that can be viewed in any plane. The radiation dose is around 100 times that of a plain wrist radiograph, although in real terms, this is still only the equivalent of 3 days of background radiation. While CT scanners are very available in many healthcare systems, there are many parts of the world where access may still be limited. There is also an increased cost of equipment and specialized staff required to run them. Also note, your patient must be able to lie flat with their arm above their head to get a good quality scan, something we must bear in mind with potentially polytraumatized patients. CT scans give us excellent assessment of bony anatomy in multiple planes. In this case, they clearly show a lunate and radial styloid fracture, giving lots of information to help plan operative intervention. Additionally, the CT software can help build impressive three-dimensional reconstructions, which some people find helpful when planning interventions. MRI scans have the benefit of requiring no radiation, but their access is limited in most scenarios due to their cost to run, the significant time required for scans, and the specialist staffing needed to run them. Again, it is important to remember that the patient must lie prone with their arms above their head in a far more restricted piece of equipment. It's also important to remember that any metalwork in the vicinity of the wrist will give a lot of artifact, which can sometimes render the scan useless. The use of MRI has, however, given us an exceptional view into the wrist, particularly when assessing soft tissue injuries or pathology. The T1 weighted sequence helps to light up tissues containing fat, including bone marrow. Fluid and cortical bone appear black. T2 weighted sequences light up water-containing tissues brightly, defining soft tissues in particular very well. An MRI arthrogram is often used to better visualize articular surfaces and ligamentous structures within the wrist. It is important to remember that this is a highly complex area, and what structures can be identified is very much dependent upon the skill level of the radiologist reviewing the scan. So to summarize, we've covered these areas during the talk. Thank you for listening. We will now move on to some quiz questions.
Okay. Thanks, Krish. That was really great. I will launch the carpal imaging quiz, so I hope everyone was listening. And I'll start my timer. So first question, a true lateral wrist radiograph is defined by the following bones in which order from volar to dorsal? Single choice for that one. Second question, which of the following phrases is incorrect? I won't read out every sub-question. Okay, third question. Pick one correct answer. A CT of the wrist is ... Okay, right. I'll stop it there. Oh no, there's a sudden jump. Keep it going for a bit longer then. Yeah, plateaued out. Okay, I'll stop the question now and show the results. Okay, so if you were listening carefully, the correct answer is scaphoid, pisiform, and capitate, SPC. Which of the following correct phrases is incorrect? Only the true anatomical axis of the scaphoid can be used to measure the scapholunate angle. That's not true. And then on the third question, the correct answer was about 100 times the radiation dose of a wrist radiograph. Okay. Okay, back to you guys.
Thanks, Alex. Thanks, Alex. And thanks, Krish, for that excellent talk on wrist imaging. I think we would love some questions from the audience as well. While we are waiting for some questions from the audience, I think I'll introduce the next speaker, Dr. Nick Jadonsky from Devon. So he'll be delivering a talk on scaphoid fractures. Thank you.
Hello, my name is Nick Jadonsky. I'm an orthopaedic hand surgeon in Barnstaple in North Devon in the UK, and I'll be talking to you about scaphoid fractures. The scaphoid's a funny little bone. It's covered in articular cartilage through almost its entirety, and there's only a very small area that arteries and nerves can actually reach it. Therefore, it has a habit of not healing. Patients who get scaphoid fractures tends to be young manual workers, sportsmen, fighters, and they're unreliable characters with unreliable histories. It's important to get the injury date and find out any treatment that they've had since their injury, and also their social history, including smoking, work, hobbies, and handedness. When you initially examine them, then there are various tests that you can use. There are at least 10 described, and use a combination of at least 4 or 5 can give you a more sensitive answer as to whether or not you think it's broken, regardless of whether x-rays are normal. The scaphoid test should be more painful than palpating elsewhere in the wrist. Don't forget your neurovascular examination. And if x-rays are negative, but clinical tests suggest that you think there's a scaphoid fracture, then you should treat it as fractured until proven otherwise. The guidelines suggest that a splint is okay, but I find patients don't come back to clinic and see you. They just get rid of the splint and don't wear it. Therefore, I prefer the emergency department to put a cast on. Even better, they should organise an MRI scan, or if not, then you can do that in clinic to exclude a fracture. There's no point seeing them 10 days later and re-x-raying them because they're virtually always the same. You just get an MRI scan as soon as you can, and then they don't need to be in cast unnecessarily. Where's your wrist sore, please?
Around here.
Okay, fine. Take your elbow to your side. Bend your wrists forward. It's a bit safer and go back for me. It's a bit sore as well, is it? Okay, you turn your wrists in. Turn around. Okay, just open your fingers. Move your thumb to the base of the little finger. Okay, can I borrow your thumb? A bit sore in there. Yes.
Yeah.
Okay. So under there.
Yeah.
I'm going to push on your thumb and squeeze it in. Is that sore?
Yeah.
Good. Put your fingers together like that for me. Hold them together. Don't let me pull my thumb out. As strong as you can. Right. Pull onto my hand. You try and turn your hand palm down. Right. Don't like that. Okay. Now try and turn it palm up. Really sore. Okay. So, saving the best till last, resisted supination I find is the most sensitive test for a waist fracture. It basically tightens your radius scaphocapitate ligament across the waist of the scaphoid, causing a humpback deformity, which is painful. So it's the most sensitive test for a fracture, and also the most reliable test for answering the question is it united yet, when they come out of cast or after treatment. So scaphoid x-rays, you need 4 views because it's a funny shaped bone. You get your usual PA and lateral for a wrist x-ray, and then you also do a PA with ulnar deviation, which extends the scaphoid, and then you get a 45-degree pronated oblique view. If you're still unsure, then you can get a dynamic series of wrist x-rays, or you can x-ray the thumb with an AP and lateral if you think that this is actually the source of the pain. When it comes to treatment, the distal pole has a good blood supply. That's the distalmost 25%. So for acute fractures, the mean time to union in a distal pole is only 5 weeks. So you can treat most of them in a scaphoid cast. And for me, this is a below elbow cast with 20 degrees of wrist extension and slight ulnar deviation. So it's a functional position. And if they get stiff in this position, then they'll maintain an excellent grip. You don't need to exclude the thumb. However, you can include the thumb if they have an intra-articular fracture of the STT joint, or in particularly unreliable patients who are insisting that they're going to go back to work. Trying to work when your thumb is in cast is much harder. The waist fractures are the middle 50%. The mean time to union here is 8 weeks. That means half of them will have healed if you casted them for 2 months, but half of them won't and will actually need casting for longer. And this causes a permanently stiff wrist. If you've got other wrist fractures, then you should fix the scaphoid. Or if it's an isolated scaphoid fracture, but it's displaced more than 2 millimeters on a CT scan, then you should fix it because the intraosseous blood supply is disrupted. But if it's undisplaced, this is where the main debate lies. The SWIFT trial, published in the Lancet in 2020, is an excellent multi-center randomized control trial comparing early screw fixation versus casting. This suggested that the casting was best in this situation, but you should CT them at 8 to 12 weeks and fix those who haven't united more than 25%. The flaws are that it's a crossover trial, but with intention to treat, which is okay. But most fixed patients with a screw were also casted postoperatively for quite a long time. So the study found no difference in range of motion or return to work between the 2 groups. Personally, I fix patients who want to return to work or sport early. I mobilize them from week 2 after fixation so they don't get a stiff wrist. And I've noticed quite a big difference in my patients with a better range of motion and early function in those who are fixed. When I fix them, I do it percutaneously under local anesthetic or Walland, using local anesthetic around the distal scaphoid, around the either side of the scaphoid, and 5 mils into the radiocarpal joint. You can reduce most of them closed by bending your wrist back over a rolled up drape, which reduces the humpback deformity. Yeah. And then it's just a simple cannulated screw over a wire. A 5 millimeter incision is closed with 1 dissolvable suture. And it only takes 10 to 15 minutes to do the whole thing. That's patients who present 6 to 9 weeks after their injury. It's quite a common thing because they think that it's just a sprain. It's not that sore. My theory is that it's probably got a poor nerve supply, just as it's got a poor arterial supply. Anyway, that period of 6 to 9 weeks not immobilized in a cast causes micromotion within the bone, so disrupting the intraosseous blood supply, causing a higher non-union rate in a cast. Therefore, you should fix them. You can CT them first to decide whether or not there's a hole in the bone that needs bone grafting, or whether you can do it percutaneously, and also how bad the humpback deformity is. Proximal pole fractures, that's the proximal quarter or 5th in some papers. Their mean time to union is 16 weeks. That's half of them will have healed with 4 months in a cast and will cause a permanently stiff wrist. Therefore, you should fix them. Again, you can do this Walland. You can do it through a dorsal mini open approach in order to protect the extensor tendons and make a small capsulotomy and hold the soft tissues out of the way, whilst you put an antegrade guide wire in. I then use a slightly smaller cannulated headless screw because the proximal pole of the scaphoid is completely covered in articular cartilage that I don't want to damage. Scaphoid non-union occurs at least 3 months after injury usually, sometimes because they presented late or because they've had failed treatment, either conservative or operative. It's important to ask them about their smoking history and they're taking non-steroidal anti-inflammatory drugs, which can also cause non-union, such as ibuprofen. The natural history of scaphoids that are untreated are that they will virtually always develop a scaphoid non-union advanced collapse pattern of arthritis. Therefore, you should try and fix them and graft them before they get arthritis. It's quite a difficult counsel in a patient who has a painless non-union, but I still offer them surgery to prevent arthritis and worse salvage options than fixing it in the first place. I usually get a CT for surgical planning to find out whether or not I need a corticocancellous graft. And if I am suspecting avascular necrosis, then sometimes I request an MRI scan with gadolinium, which gives me a picture like this. For those patients, then I can plan more time to do a vascularized bone graft. So for waist fracture non-unions, I use a volar approach. You can correct the humpback deformity using a corticocancellous wedge graft, which I usually take from the distal radius, but occasionally from the iliac crest or distal femur. I use a retrograde 3mm headless screw through the whole scaphoid and graft. If I need to vascularize it, then it's exactly the same graft taken from the distal radius, but I spend a bit more time picking out the artery along the distal edge of the pronatal quadratus, and this is called a Kuhlmann's vascularized graft. For proximal pole non-unions, I use a dorsal approach. There's usually no humpback deformity because it doesn't bend over that radioscaphocapitate ligament. Sometimes you need to make a window in the articular surface in order to find the fracture, and then use a tiny ENT curette to scoop out the dead bone and then pack it with cancellous graft and fix with a antegrade headless bone screw. You can take this bone graft from Lister's tubercle on distal radius, but if you think that it might not unite and you may need to do a vascularized graft later, then you should save the distal radius unused and take bone graft from either the pelvis or the olecranon, as I have done in the lower right picture there. Sometimes you get a very thin eggshell cortex with a very small fragment that can explode when you advance a screw. So you need to talk about plan B salvage procedures in advance of fixing it if your CT suggests this might be the case. Avascular necrosis is more common in proximal pole fractures, so you may need to do a vascularized graft. For proximal pole fractures, I use a Zeidenberg's, which is a 1-2 intercompartmental supraretinacular vessel. You use a dorsal approach, which is hockey stick towards the first web space, which allows you to reach over to the dorso-radial aspect of the radius to get between the first and second extensor compartments and highlight your vessel within the extensor retinaculum. You then do a radial styloidectomy, which gives you a good view of the scaphoid non-union, and you can take your radial graft from the radius just proximal to where you've done your styloidectomy. You can then flip it 90 degrees and fix it into the scaphoid with its pedicle using an antegrade screw. Here's one case of non-union in a patient that I did actually fix. They presented late, though, with a displaced waist fracture. I fixed it 19 days later as it was difficult to get into theatre. And because it was quite displaced and a delayed presentation, I did cast them for 6 weeks as well as doing the screw. But I didn't use any bone graft. They presented at 6 weeks in fracture clinic and their cast was in bits because they admitted to have been fighting whilst wearing the cast. Unfortunately, the screw looked like it had loosened, but we gave it a chance and casted them for a further period of time in the hope that it would unite. They were seen by one of my registrars in clinic and discharged. However, they presented 2 years later with a painful non-union and a toggling screw. This is quite a difficult problem, as they then had a huge hole around the screw, which you then can't put a bigger screw into very easily. Instead, I removed that screw, scooped out all the dead and hard bone from inside the screw hole and packed it with cancellous graft. I then used a cortico-cancellous wedge graft into the non-union gap. And this is one of the few times I've used a scaphoid locking plate from modalities with a non-vascularized bone graft. At 3 months, they had united, but as you can see, it's quite a large graft that I took from the distal radius. So in summary, scaphoid fractures, you need to have a high index of suspicion, and you need to combine several clinical tests to exclude a fracture. The MRI scan them if you're in doubt. With distal fractures, you can treat them conservatively. Proximal fractures, you should fix them. The waist fractures, there is some debate. You should fix them if they're displaced, delay presentation, or if they're combined with other wrist injuries. However, if they're undisplaced, the SWIFT trial suggests you should treat them conservatively in a cast. But if they want early return to work or sport, then I offer them an early fixation and cast them for 2 weeks maximum. Scaphoid non-unions, most of them will develop a slack wrist if they're left untreated. Therefore, you should fix and graft them. Waist fractures have a humpback, so use a cortico-cancellous wedge graft. Proximal pole fractures, you can usually get away with cancellous graft only. You should vascularize your graft if they have avascular necrosis. And if they've already got arthritis, then don't try and fix it at all, but instead go to salvage procedures that Jonathan will talk about in a bit. The BSSH are just finalizing a draft protocol for scaphoid fractures that will be available on the BSSH website soon. Thanks a lot for listening.
Thank you, Nick. That was a great talk. Particularly like the scaphoid fixation under Wallant. We're now going to have some quiz questions. So Alex, you okay to tee those up?
Yep, just launched them. I'll try and give you a bit more time than last time. So first question, what is the mean time to union for a conservatively managed proximal pole scaphoid fracture? That was definitely in Nick's talk. Okay, question 2, what is the most useful, so sensitive and specific, clinical test for a scaphoid waist fracture? And the last question, for those that can be treated conservatively, what type of immobilization is best for treating scaphoid fractures? Okay, I think I'll stop it there. And I'll share the results with you. So first question, what's the mean time to union for a proximal pole fracture? 16 weeks. Second, what's the most useful clinical test? Resisted wrist supination. So save the best till last, Nick said. And the last question, I think the majority of you got this one right. Below knee cast, excluding the thumb, is the best type of immobilization for a conservatively managed scaphoid fracture. Okay.
Thank you, Alex. We're getting a few questions in the Q&A section, which is great. I noticed that Karen's asked about MRI rather than CT for scaphoid fractures, which Nick has answered in the Q&A chat. I think one thing we probably all agree on is that while MRI is gold standard, has been proven to be more sensitive, the availability can vary quite a lot depending on where you work. So I think in some situations, people will use a CT scan for suspected scaphoid fractures because that's what their local setup will allow. So that always comes into play with these sorts of things. I'd like to now hand over to Jeremy, who's going to talk about perilunate injuries.
Good afternoon. My name is Jeremy Stanton, and I'm a consultant upper limb surgeon doing shoulders all the way down to the hand, actually. And I've been working in Colchester as a consultant for the last 22 years. I'm going to be talking to you today about perilunate injuries. One should say from the outset that perilunate injuries are pretty rare injuries. I'm one of 3 upper limb consultants, stroke hand consultants at Colchester, serving a population of about 450,000. And we probably don't get any more than 1 or 2 per year, and that's between 3 of us. And this would concur with the rates of less than 1 per 100,000 per year. These injuries are also often missed. It's said that 1 in 4 injuries are missed at initial presentation. The X-rays are very abnormal, and so it's rather counterintuitive that they would be missed. But I think this is in no small part down to the rarity of the occurrence of this injury. These injuries, if they are missed, can lead to chronic long-term problems in terms of progressive osteoarthritis, both in the mid-carpal and radiocarpal joints, increasing pain and dysfunction, certainly in the case of a lunate dislocation, median nerve dysfunction as well, weakness of grip, and ultimately a CRPS. The best time to definitively deal with these injuries is as quickly as possible, certainly within the first few days. Perilunate injuries probably can be reduced up to about 3 months, but lunate dislocations may be reducible by about 3 weeks as a result of ligamentous contraction. The X-ray and the CT scan, as viewed, show the outcome of a chronically missed perilunate dislocation. A very disordered looking carpus on the AP view of the wrist, and the CT and the sagittal CT shows evidence of a rather distorted looking capitate articulating with the dorsum of the lunate with periarticular cyst formation and obvious arthritis. This is the first case I want to present. He in fact presented to our department last year. He was a 27-year-old male, keen weightlifter, and he fell whilst powerlifting, falling on his outstretched wrist. He had severe pain presentation and actually with median nerve symptoms at the time as well. Interestingly, looking at just simply the AP view, one could see how this injury might be missed. There's a hint that it looks abnormal, and there appears to be an overlap between the scaphoid and the lunate. The lunate does look slightly triangular, with the apex of the triangle superimposed by the capitate, but overall, it doesn't look hugely abnormal. However, when you look at the lateral picture, the picture becomes much more clear, and this is a classic perilunate dislocation, with the lunate still within the lunate fossa of the radius, although slightly inferiorly inclined, and the capitate lying over the dorsum of the lunate. The mode of injury is said classically to be a fall on the extended wrist with some ulnar deviation with some intercarpal supination. It said that this leads typically to a lesser arc injury, i.e. ligamentous injury, whereas if the wrist is radially inclined at the time of injury, embedding the scaphoid within the scaphoid fossa, a scaphoid fracture, i.e. a great arc injury, is more likely. Contrary to popular belief, however, is that a scaphoid fracture and a scapholunate injury can coexist within the same injury. Perilunate dislocations are fairly complex carpal derangements arising, as discussed previously, as a result of loaded hyperextension of the wrist with some intracarpal rotation. The pattern of injury is very much dictated by the complexity of the ligamentous connections between the carpal bones. And I'm sure, like me, you'll have spent a period of time at some point in your training looking at the various connections between the carpal bones via the roller wrist ligaments, remembering the names of these ligaments for a short period of time and then rapidly forgetting them. Nevertheless, carpal instability and destabilization undergoes what's known as a progressive perilunar instability, as described by Mayfield, arising usually on the radial side and then progressing stepwise around the lunate to the ulnar side. However, ulnar-sided commencement of the instability can exist. We've already discussed previously the separation of these injuries into lesser arc and greater arc injuries. The lesser arc said to be purely ligamentous injuries, the greater arc involving fractures of one or more carpal bones, and in addition, potentially involving fractures of the radial or ulnar styloid. The picture top right is a diagrammatic interpretation of the roller wrist ligaments, and the bare area is this space of Poirier devoid of some of these extrinsic ligaments, which is a potential weak spot for the lunate to dislocate into. The two x-rays that you can see on the left shows a perilunate dislocation, and on the right a lunate dislocation, but actually these are effectively the same injuries, and part of the progressive perilunate instability pattern. This slide shows the Mayfield sequence in rather more detail. In stage 1 of the Mayfield sequence, the hyperextended wrist results in extension of the trapezium, which then extends and supinates the scaphoid due to the intact scaphotrapezial ligaments and the scaphocapitate ligaments. The lunate, on the other hand, can't extend as it's constrained by the radiolunate ligaments, as a result of which, because of the torque involved, the scapholunate interosseous ligament can then tear, usually starting palmally, because this is the weaker part of the ligament, and then extending dorsally. If the wrist is radially deviated at the time, a scaphoid fracture may result. But as discussed previously, both a scaphoid fracture and a scapholunate ligament can coexist in the same injury. In stage 2, if the extension force continues, the capitate can actually leave the concavity of the lunate, depending on the position of the wrist at the time of injury. If there is a scaphoid fracture, this can result in a trans-scapho-perilunate dislocation. And if the head of the capitate fractures, this can result in a scaphocapitate syndrome. In stage 3, as the distal row dislocates dorsally, the ulnar side of ligaments then become very taut, ultimately resulting in either a tear of the lunar triquetral ligaments or a sagittal fracture through the triquetrum. In stage 4, all of the perilunate ligaments are torn, such that only the dorsal capsule and palmar radiolunate ligaments remain intact. The tension on the carpus as a result of the extrinsic forearm muscles compress the capitate into the radius, propelling the lunate palmally out of the lunate fossa, resulting in a lunate dislocation. Thus, it can be seen that even with a complete dislocation of the lunate, there usually does remain some blood supply to the lunate itself. The picture on the right nicely demonstrates the relative absence of ligaments volar to the lunate, representing the space of Poirier. Thorough examination of the AP radiographs is mandatory. Gilula's lines represent the proximal articular surface of the proximal row, distal articular surface of the proximal row, and the proximal articular surface of the distal row. These should all form nice smooth lines. It can be seen on the right-sided X-ray that clearly the Gilula's lines have been broken, and clearly this is an abnormal AP X-ray. Obviously, we'd also be looking at a lateral X-ray to confirm the diagnosis. So going back to our 27-year-old weightlifter, he was seen in A&E in significant pain, a very swollen wrist with evidence of median nerve dysfunction. Quite unusually, his dorsal perilunate dislocation was reduced in A&E. I say unusually because getting a decent reduction often requires prolonged traction and also muscle relaxation in the majority of cases. The shorter the interval between the time of injury and diagnosis, the easier closed reduction is. Closed reduction is carried out using Tavernier's technique, which includes traction in the affected wrist, often up to about 10 minutes. This then disimpacts the mid-carpal region. The wrist is then extended whilst in traction, and then with a thumb over the volar aspect of the wrist, putting pressure on the volar aspect of the lunate, the thumb in traction is then brought into flexion. The opposing thumb prevents any further migration of the lunate, and this then snaps the lunocapitate joint back into joint. The wrist is then splinted, and the post-reduction X-rays need to be very carefully assessed. In the vast majority of cases, subsequent open reduction and internal fixation is required, but the PA radiograph needs to be carefully assessed for any evidence of increased gapping between the scaphoid and lunate, to look for abnormal flexion or extension of the carpal bones, and for any evidence of fracture displacement or loose fragments lying within the joint. As discussed in the previous section on the Mayfield sequence, these injuries always include significant ligamentous disruption, and only open reduction and internal fixation allows assessment and repair of these ligamentous injuries. Open reduction and internal fixation should normally be done from both dorsal and volar approaches. The dorsal approach allowing accurate reduction of the lunate and repair of the dorsal aspect of the scapholunate interosseous ligament, and the volar approach allowing both the carpal tunnel decompression and the repair of the volar aspect of the lunotriquetral ligament, which is the stronger part of this ligament. The rent in the volar capsule can also be also be repaired. These are some more radiographs of our 27-year-old weightlifter. The above X-rays demonstrate wiring between the scaphoid and lunate and between the triquetrum and lunate. And if there's any anxiety about the lunocapitate joint, a wire can also be placed between the scaphoid and capitate. You can see in the lunate there's also evidence of a micro bone anchor. I would normally leave the wires in for a minimum of 8 to 10 weeks, and then these are then removed under a GA as they've all been cut deep to the skin, full stop. The bottom two X-rays are X-rays taken at the 2-month post-removal of K-wire stage, showing good alignment of the carpal bones. As discussed previously, greater arc injuries also involve fracture of one or other carpal bones, in addition to the perilunate dislocation. The commonest greater arc injury is a transscaphoid perilunate fracture dislocation, which actually represents 60% of all perilunate injuries. Thus, greater arc injuries are more common than lesser arc. The capitate can also be fractured in addition to the scaphoid, resulting in the so-called scaphocapitate syndrome. The triquetrum can also be fractured in addition to a rupture of the lunotriquetral ligament. Case number 2 involves a 36-year-old male who actually presented at the 4-week stage post-injury in the fracture clinic in Blantyre and Malawi. The lateral view shows a clear perilunate dislocation, but the AP view also shows that the scaphoid doesn't appear normal, and indeed this represents a transscapho perilunate dislocation. In the acute greater arc injury, in fact, initial treatment is exactly the same as with a lesser arc injury, using Tavernier's method to achieve a reduction. Clearly, this case is rather more chronic than our 27-year-old weightlifter, but even in this case, an initial closed reduction was possible. Open reduction and internal fixation is also the treatment of choice in these greater arc injuries. In these acute injuries, bone grafting the scaphoid is usually not required, An internal fixation is normally carried out with a headless compression screw with K-wire stabilization as described previously. If there is injury to the scaphoid ligament, in addition to the scaphoid fracture, this also needs to be repaired using micro bone anchors. As discussed previously, the wrist then needs to be immobilized for about 8 weeks with K-wires removed at that stage. It cannot be stressed enough that these injuries are severe injuries, and patients need to be counselled from the start that it is likely they'll never end up with a normal wrist again. Less than 1/3 of patients end up returning to occupations involving heavy manual work. Less than 1/2 end up with either an excellent or good functional result. Grip strength is usually only about 70 to 80% of normal, and the risk of late onset arthritis is high. My third case involves a gentleman who I saw very early on in the beginning of my consultant career, referred from another team, 21-year-old chap who'd fallen downstairs and was treated as an old scaphoid fracture for 6 weeks, treated in the plaster of Paris. Armed with the information we know now, there was a clear scaphocapitate syndrome here with a 180-degree rotation of the head of the capitate. However, this fragment seems to lie perfectly within a space with a seemingly normal joint space circumferentially around it. An example, perhaps, of something being so abnormal that it starts to look normal. With wrist hyperextension, the capitate fractures over the dorsal rim of the radius, and as the deforming force is relaxed, the reducing remaining body of the capitate rotates the head of the capitate 180 degrees. This fracture was fixed with 2 headless compression screws from a dorsal approach. Movements at the 3-month postoperative phase were very poor, but by the 2-year stage, his movements were much improved and he was actually functioning reasonably well. He was then subsequently lost to follow-up. Thank you very much for your attention.
Thanks, Jeremy, for that excellent talk. I think we'll move on to some questions to Alex. Thank you.
Okay. Right. The perilunates, that was a great talk. Regarding lesser arc injury, perilunate dislocations, and then tick all that are true. Okay, question number 2. Regarding greater arc injuries, perilunate fracture dislocations, and then tick all that are true. So it could be more than one right answer. And question number 3, perilunate injuries, quite open-ended, and then tick all that are true. So there's quite a few streams to these questions, so I'll give you a bit longer. Okay, I'll stop it there. Right. Regarding lesser arc injuries, perilunate dislocations. So the lunar triquetral ligament should be repaired, and the first ligament to fail is the scapholunate ligament. So those were the two correct ones. For the second lot of questioning, regarding greater arc injuries, perilunate fracture dislocations. Well, the method of reduction is the same for lesser arc injuries, that's true. Scaphocapitate syndrome is easily missed, and the scaphoid should invariably be fixed. And then moving on to the third set of questions, perilunate injuries. They do affect the volar ligaments more than the dorsal. The volar leaf of the lunar triquetral ligament is stronger than the dorsal, and it often affects the median nerve. Okay. Right. Back to you, Krish.
Right, thanks, Alex. I think. Thank you, Alex. Thanks. So our next talk is going to be on non-scaphoid carpal injuries, and Dr. Saman Renuka from Sri Lanka will be doing that talk. Thank you.
I am Dr. Saman Renuka, consultant orthopedic surgeon from Sri Lanka. We are going to talk on non-scaphoid carpal injuries. Carpal injuries can be bony, ligamentous, or combination. We have to look for carpal bone fractures because some fractures are not obvious in standard X-ray views. If we suspect, we have to order special views or special imaging like CT or MRI scanning. Carpal bone fractures account for around 8 to 19% among all hand injuries, and majority are scaphoid fractures. And the second most fractured carpal bone is the triquetrum. It is important to identify carpal bone fractures at the early setup. Then we can start early management, and depending on the success, there is a high chance of early mobilization and good functional recovery of the wrist. Triquetral fractures are the second most common carpal bone fracture, and that accounts for around 15% of all carpal fractures. It can be associated with distal radius or ulnar fractures and perilunate dislocations. Triquetral fractures can be dorsal cortical fractures, body fractures, or palmar cortical fractures. Dorsal cortical fractures is by far the most common fracture. That can be avulsion, shear force, or impaction. It is interesting to identify the whooping duck sign in the lateral view of the wrist X-ray. When we order X-ray, we can ask for AP, lateral, and 45-degree pronated oblique radiograph of the wrist. There will be swelling and point tenderness on palpation directly over the triquetrum in this patient, where we can see the swelling. Generally, it needs a high amount of injury to cause triquetral body fracture. Fractures of the body of the triquetrum are occasionally seen with perilunate fracture dislocation. And there are 5 categories in triquetral body fractures. Palmar-cortical fracture is an avulsion type of injury. The fracture occurs at the insertion point of the ulnar triquetral ligament and the lunar triquetral interosseous ligament. Dorsal cortical fractures are most of the time managed with wrist splint or cast for approximately 4 to 6 weeks. Immobilization is recommended because of the importance of 2 dorsal ligaments to proximal row stability. MRI scan can be obtained to identify intercarpal ligament injuries or occult fractures. Body fractures are managed with open reduction if the fracture is displaced or if there is instability. Open reduction can be done through dorsal ulnar approach, radial to the extensor carpi ulnaris tendon. Fixation can be done with K-wires or interfragmentary screws depending on the fracture fragment size. If there's a ligamentous injury, suture anchors can be used. Non-union of the triquetral body fractures are rare. If it is symptomatic, bony fragment can be excised. Other complications are persistent carpal instability and pisotriquetral arthritis. Treatment for pisotriquetral arthritis is excision of the pisiform bone. Then we look for hamate fractures. Hamate is a triangular shaped bone with hook and body. Most of the fractures are hamate hook fractures. Those are secondary to faults. We can look for point tenderness if we suspect hook of hamate fractures. If there is chronic hamate hook fracture, patient may complain paresthesia or weakness in the ulnar nerve distribution. This is a patient with hook of hamate fracture. There's a special examination, that is resisted flexion of the ring and little fingers. In this provocative test, there will be pain when the tendons are compressing over the hook of the hamate. Hamate body fractures can be associated with dorsal fracture dislocation of the 4th and 5th metacarpals. We can see relative shortening of the 5th metacarpal bone in this X-ray. Hamate fractures are best managed conservatively. If there is painful non-union, the fragment can be excised. If the fracture is associated with the base of the 5th metacarpal bone, fracture can be reduced and percutaneous transfixation K-wires can be utilized. If patient undergoes open reduction, that is through the dorsal approach. Fixation can be done with K-wires or screws. Excision of the hook of the hamate nonlinear can be done through Palmer approach, either carpal tunnel or Guyon canal approach. Capitate fractures are very rare and rarely occurs in isolation. It is most of the time associated with scaphoid fractures or transscaphoid transcapitate perilunate dislocation. Body fractures can occur in hyperextension of the wrist, axial load, or direct blow. Here we can see the 180-degree rotation of the proximal pole in hyperextension injuries. Capitate is rigidly anchored to the base of the third metacarpal bone. So it makes the central column of the hand and wrist. So fractures of the capitate are most of the time associated with transscaphoid perilunate fracture dislocation. Here we can see transverse body fracture in the capitate. Non-displaced capitate fractures can be managed with short arm thumb spica cast for 6 to 8 weeks. If the fracture is displaced or associated with perilunate fracture dislocation, headless screws can be used. And we have to especially be aware of 180 degrees rotation of the proximal pole. Fractures of the body of the lunate usually occurs from distal axial compression at the head of the capitate and is driven proximally into the lunate fossa. We have to look for the carpal instability if there is lunate fracture. If there is no subluxation or dislocation or instability, those can be best managed with casting. If there is a fracture subluxation, the fracture has to be fixed and the carpus should be stabilized. This is the lunate body fracture. And the Thiessen classification describes the fracture pattern depending on the site of the fracture. So the avulsion fracture of the dorsal portion of the lunate has to be managed as ligamentous injury of the scapholunate interosseous ligament. Non-displaced fractures can be managed with cast immobilization with close follow-up for any displacement. The open reduction can be done for the dorsal fragment or body fragments dorsally. And if there's a volar fragment, that can be fixed with carpal tunnel approach. Osteochondral fragments can be managed arthroscopically or approach into the joint through dorsal incision. Trapezial fractures are very rare, and most of the time that is associated with Bennett fractures or distal radius fractures. Patient presents with trauma to thumb, and we can look for the point tenderness at the base of the thumb if there is suspected body fracture. And there can be point tenderness over the base of the thenar eminence if there is trapezial ridge fracture. So trapezial fractures can be ridge fractures, body fractures, or fracture dislocations. Body fractures can be identified in standard PA, pronated AP, and lateral views. Carpal tunnel view can be ordered if there is suspicion of trapezial ridge fracture. CT scan helps to identify occult fractures and to identify displacement and the size of the fragments. And it is also helpful to identify the articular involvement. This displays body fracture. Ridge fractures occurs most of the time on fall on outstretched hand. And this is a kind of avulsion type injury due to the insertion of the transverse carpal ligament. Non-displaced body fractures and ridge fractures can be managed with thumb spica for 4 to 6 weeks. If the fracture is displaced, fracture can be fixed with interfragmentary screws or K-wires. If there is associated OA in the base of the thumb, primary trapeziectomy can be done. This X-ray shows with percutaneous fixation of the trapezium, and the other one shows interfragmentary screw compression of the trapezium. Pisiform is a sesamoid bone of the flexor carpi ulnaris tendon that can happen in direct trauma or fall on outstretched hand. Patient may complain ulnar side wrist pain or grip weakness, and we can look for the tenderness or the base of the hypothenar eminence. Standard PA or carpal tunnel X-ray views can show pisiform fractures, and if there is suspicion, we can go for CT scan. Pisiform fractures are best managed conservatively. Patient can undergo short arm cast application with 30 degrees of wrist flexion and ulnar deviation for 6 to 8 weeks. Most of the fractures will heal. If there is painful non-union or post-traumatic osteoarthritis, excision of the pisiform can be done without reduction in power grip. Trapezoid fractures are very, very rare in isolation. In summary, we have to look for carpal bone fractures, and then we have to identify whether it's stable or unstable. If it is stable, early mobilization is very successful, and the patient should be reassured that the pain will be there for several months. If there's painful non-union, fracture fragment can be excised. Thank you.
Thank you, Saman. That was a great talk covering quite a wide range of injuries. We're going to move straight on to Jonathan Jones's talk, before then having a slightly bigger discussion session at the end. Can I please encourage all the audience to put their questions in, and we'll try and pick some of those out for the final discussion session. So next on to Jonathan's talk.
Good morning. My name is Jonathan Jones. I'm a hand and wrist surgeon from Peterborough, the UK, and currently working at Community Central Hospital in Malawi with variable connectivity. I'm going to give you my thoughts on salvage surgery for wrist arthritis in relation to carpal injuries. Firstly, this is a scaphoid fracture, which is a common injury, and in 90% of cases heals uneventfully without any functional problems in relation to the patient. As we know, some of these do not heal, and they can progress to arthritis, which requires some form of salvage surgery. This is a snack wrist scaphoid non-union advanced collapse. The grading is 1 to 3 and shows the progression from the radial side to the mid-carpus and the lunate capitate joint. There's usually sparing of the lunate fossa. Evaluation of the X-rays is important for any carpal injury at the beginning in the acute phase, but assessment with Galula's lines, and the other parameters are just as important in assessing the acute wrist as the salvage situation. And we can see on the arthritic wrist the loss of carpal height, the complete obliteration of the mid-carpal joint, and the altered contour of the proximal row. And this comes into play when planning. So the treatment options for the salvage case, although there are complex procedures which we would more likely to be effective, it's always important to start with the simple methods such as splinting and hand therapy. And this is really just more often to gain a rapport with the patient and also get a better understanding of the injury and his symptoms. X-ray guided steroid injections can help to target which joint might be causing pain. Then a simple procedure may in fact buy time before a definitive procedure is required. Radial styloidectomy, or possibly a denervation. Then the more complex procedures, such as a Chamay fusion, that's a radioscaphoid fusion or radiolunate fusion, or an intercarpal fusion between the carpal bones, lunate capitate hamate tracruitral, it's a 4-corner or just a 3-corner, lunate capitate hamate. Sometimes an STT fusion may be appropriate, or possibly rarely, but a scaphoid capitate fusion. Insertion of an interposition or a spacer can be affected, such as the STPI in STT joint, STT arthritis. Proximal carpectomy is also a very good option in certain cases, as long as the proximal pole of the capitate is in reasonable order. Total wrist fusion is the last resort, because effectively this removes the wrist function in terms of flexion and extension, and also radial and deviation. So motion preserving options should be tried first. Wrist replacement needs to be taken into consideration, but the risks of revision may outweigh the functional benefits, and in some cases may not be durable for the patient. But with the improving implants, this remains an option. This is a case to illustrate some of the thoughts we might be going through when we're assessing a case. This is a case referred to me who'd had an injury whilst cutting a hedge. He had an electrocution because he cut the cable and had a severe wrenching injury to his wrist. He had severe pain and was treated with a radioscapholunate fusion, but he had ongoing pain, significant pain, which is mainly radial sided. It looked as though there may be possibly a non-union between the radius and the scaphoid, or possibly the radius and the lunate. It was consented for a total wrist fusion and exploratory surgery, but with the idea of trying to preserve the mid-carpal joint if at all possible. At operation, it was found that the radiolunate and the radioscaphoid fusion were intact and had fused well, but he had the staple had caused a further fracture within the scaphoid bone mass. This was treated with bone graft and a plate, and his symptoms, his preoperative symptoms, resolved. In this case, we were able to preserve the mid-carpal joint. This is a good illustration of where possible, trying to preserve movement. 72-year-old gentleman is the next case, who's retired and likes fishing, and developed scapholunate dissociation in both wrists. And one wrist, the left wrist, was developed first, followed by the right wrist. This is the early stages, and you see the stylocarpal impingement. This was treated really conservatively at the beginning, and with splinting and injections. This is the Watson staging of 1 to 4, showing the progression of arthritis to the radiocarpal and the intercarpal joints, again from radial to ulnar, with sparing of the radiolunate joint in most cases. The patient had a 4-corner fusion for the right side, and this he actually required a revision of the lunate tracruitral joint because of ongoing pain, and this was treated with a headless bone screw. This is his fishing rod holding arm, and he was able to radial and deviated, and in fact he said it improved his technique. So for him, the specific operation worked. He developed the same symptoms on the left side, and was seeking a further treatment on the left side. This is an example. This is the diagrammatic version of the Watson staging, and he had reached at least stage 3 to 4. I elected to do a proximal carpectomy with him, and the needle on here just shows the distal pole of the scaphoid, which can sometimes be removed through a small volar approach. This gave him good rotatory movement of his wrist so that he could handle his fishing line and feed the line with his left hand, with his left wrist, and he was very pleased with the outcome. It's unusual to do for the same condition different procedures on both sides, but it illustrates the that you need to sort of tailor the operation for the patient. He was a little bit older, and I felt that that a carpectomy would be better than the four-corner fusion. The third case is a 21-year-old gentleman who fell downstairs and had an apparent scaphoid fracture. This is the way it was treated. He was put into a cast for 6 weeks. Closer evaluation of the x-rays at a second appointment showed that there was some additional lines in the carpus, and there was it looked like there was an extracarpal bone. This is quite an unusual condition called scaphoid capitate syndrome. That's where the capitate is fractured as part of the injury complex. This is a greater arc injury because the line goes through the scaphoid and the proximal pole of the capitate. This was treated with headless bone screws in the capitate and the scaphoid through a dorsal and a volar approach. The patient did well until a further injury, and he was developing further pain. And in fact, the scaphoid screw was impinging on the capitate at that stage because of the injury, and this was removed. And this gave him much improved range of movement. Interesting to note that the headless bone screw was starting to impinge on the lunate due to the loss of height of the capitate bone. The scaphoid and the capitate had united successfully, but as in many cases of this sort of nature, one needs to be aware that the patient may require a further operation, and in fact, given his lunate capitate impingement, likely to require either a lunate capitate fusion or even a 3 or 4 corner fusion at some point in the near future. This is an intraoperative picture of a 4 corner fusion, shows the lunate, the capitate, the hamate, and the triquetral bones. The articular cartilage needs to be removed with a curette and bone grafted, and then a plate fixed in place. You need to be aware that sometimes the plate can cause impingement, and in fact, the screw is backing out here, so there must have been some loosening at some point. This case was referred to me, and in fact, the impingement was the most painful part of this, and this required fusion conversion to a total wrist fusion. I use the CMC sparing fusion plate, and this is for all my fusions, whether it's a proximal carpectomy, rheumatoid or otherwise. I very rarely use a plate that spans the CMC joint. This gives a little bit of movement at the CMC joint, and it's also a low contour plate. Here's an example of the total wrist fusion plate, which I've found in the past that occasionally the distal fix is not secure, can sometimes need revision, and this is probably due to the moment arm and due to the length of the plate. The trend does seem to be towards CMC joint sparing plates. The last case demonstrated that a gentleman who's a 100-kilogram lorry driver who had a head-on collision with sustained severe chest injury, left wrist injury, and fractures of the right little finger as well. This is in the time of the peak of the COVID pandemic, and he was treated under regional anaesthetic. Fortunately, this block didn't seem to be effective, giving him his patient parameters, and he had his procedure carried out under Welland. Went for a definitive radioscaphoid fusion, otherwise known as a Chamay fusion, which sometimes is necessary. A bridge plating could have been an option for him, but given the significant comminution in this case, it was felt necessary to proceed to the radioscaphoid fusion. He fused successfully in the radiocarpal joint, but still had ongoing ulnar pain and DIUJ instability. And therefore he was revised to an ulnar head replacement, which resolved his ulnar site pain. Therefore, in salvage cases, sometimes a definitive procedure is required, and then a further procedure tailored to the patient's symptoms. This is an example of an STT arthritis treated with a fusion, which does lead to some loss of movement, but is effective. And this is the use of the interposition plate, the pyrocarbon STPI, which a series of about 15 cases of only which one has revised. This does seem to be effective and does improve the range, keep the movement in comparison with an STT fusion. Wrist salvage surgery does require a number of things: specialist imaging and MGT. It requires technical skill and creativity intraoperatively. It requires planning. It's time consuming and demanding, and it does require the specialist implants. All these are necessary. Mini-C-arm fluoroscopy is obviously very helpful. And then specialist physiotherapy. And at the end of these operations, they can be quite rewarding, and the surgeon can be pleased with the X-rays, something to show the patient, so forth. But it's not about the surgeon being happy. The patient has also got to be happy with the function and that their expectations have been met. So I'll go through the key factors in the decision-making when you're assessing a patient for wrist salvage surgery. Patient-specific factors are paramount. Their occupation, if they're in their 50s or 60s and they're going to retire, if they're a roofer or a plumber or someone who uses their hands manually, this operation may stop them from returning to work, as they may take them 3 to 6 months to recover from this, and their strength may not be as good as preoperatively. Are they self-employed? Have they had a past history of trauma or surgery and other comorbidities? Reevaluate the level of pain and the site of pain and see if any simple measures could work. Assess their function and their grip strength so that you can show the patient what they're going to gain from it and what they might lose. The results of imaging, CT scan, MRI scans, and so on are useful to discuss with the patient and also for the MDT on these cases, useful to discuss with a colleague. The patient's understanding of the injury and expectations of surgery are key, and also the return to work, which as some studies have shown recently, this is often underestimated by surgeons and needs to be discussed with the patient. So in summary, I've gone through some of the options for salvage surgery, the importance of a staged decision-making, sometimes 2 or 3 or even 4 different appointments with the patient going through things and gaining their understanding. Start with a simple treatment. Have a functional assessment done by a physiotherapist if possible, did some scores, and opt for the motion-preserving treatment if at all possible. At the beginning, when you do your definitive operation, is explain to the patient that if this goes wrong, that there may have to be a further operation, which may either be a total wrist fusion. So they need to be aware that there is a further surgery might be required. Ensure that patients are fully informed and that the risks and benefits and outcomes of surgery are carefully recorded for them. Ultimately, you're trying to balance the expectations of yourself and the patient. And at the end of that, if you've met the patient's needs and the operation's gone well, then the team is happy and the patient is happy. It's a very rewarding kind of case to deal with. And I hope this has been helpful for you. Thanks very much for listening.
I'd like to extend my thanks to Jonathan, even though he's not here, for a great talk with lots of really great cases. We're about to have our final discussion session now. I'd just like to once again ask the audience to please put down any questions they want answering. It's a great opportunity to ask the panel and get some opinions. I'd like to kick off by just asking Nick really first, when you were talking about your scaphoid non-unions, can you tell us a bit about the discussion process you have with those patients that are relatively asymptomatic?
Yes, so it is a difficult counsel, as I said in my talk. It depends why they presented to you, because they don't normally present unless they've got pain. So it's not many patients that are asymptomatic who present to you, unless they have a long-standing non-union on an X-ray, and then they've fallen and re-injured the wrist, and then they've ended up in fracture clinic, for instance, because they've got a sore wrist, but the scaphoid fracture is clearly old. It'll very much depend. I normally get a CT scan to see what the defect within the scaphoid is, and whether I was going to graft it, which type of graft I need, whether it's cancellous or corticocancellous, and which approach I would use. And also the CT will normally tell me whether they've got arthritis in the wrist. I think someone raised the question on a Q&A already that, when do you bail out and go to salvage? And basically, if they've got arthritis that's going to give them symptoms, then there's no point fixing the scaphoid because they're still going to have symptoms in the wrist. So that's when you go to salvage. But if they don't have arthritis in the wrist, but they do have a scaphoid non-union, perhaps which they didn't know about, then you can fairly safely explain to patients that we know from experience that most patients with a non-union in their scaphoid will go on to a scaphoid non-union advanced collapse at some point. So they will develop arthritis and it will become symptomatic. And if I treat your scaphoid non-union now, then there's a better chance that you'll retain motion and you won't need one of those salvage options later. So I will always obviously have to tell them that it's quite a big operation. You're going to be in a cast afterwards because you're going to need to take some graft from somewhere, and one screw on its own quite often isn't enough, so you need to cast them as well as fix them. So, and they might not want to take 3 months out of their life to be in a cast and then rehab and then end up with a slightly stiff wrist. But you just have to explain the natural history of scaphoid non-union, which is a bit different to a scapholunate advanced collapse. That is a slack wrist is still debatable. Lots of patients with a scapholunate injury don't go on to develop arthritis, but with a scaphoid non-union, they most of them do. So that's generally my workaround. If they've got a painless non-union or a fibrous union and they've had a little fall and it's still sore, then you can trial a period in a cast to get them back to their painless fibrous non-union, especially if they've got arthritis already and actually you don't need to do salvage yet because it's not a painful arthritis. So then I just treat them in a cast for a few weeks to get things to settle down, and then if they're still sore 3, 6, 9 months later, then you can discuss the salvage options.
Thanks for that. Yeah, but I think it's just it's a tricky discussion to have when someone's asymptomatic. But yes, it's just it's about trying to give them the information to make their decision appropriately. We have a question in the chat from Ravi Pandit. Is there a role for surgical release, brackets open or arthroscopic, close brackets, in cases with wrist stiffness without OA after a trial of conservative management and physiotherapy? Would appreciate the views. Thank you. I'm not sure the context of this scenario. I'm assuming post some sort of wrist injury, be it carpal, perilunate, maybe even distal radius. Does any of the panel have any experience of this?
Not personally, but I quite like the idea. I do arthrolysis procedures for stiff MCP joints and PIP joints. And I'm not quite sure why we don't do it on other joints, because you can get some good results if you can free up a bit of motion. Obviously, you have to create scarring in order to release it. So the worry is they just stiffen up again. I've not heard of anyone doing it for a wrist, but I do like the idea. And I guess the counsel would be that the worst case scenario is that it just doesn't work. Obviously, with the extra risks of an anaesthetic and infection and all that. But again, that would be an operation that you could do under Wallant, so you could minimise the risks, as I do for MCPs and PIPs.
Alex, you have your hand up.
Yeah, I was just going to ask Nick, when you are preoperatively assessing a scaphoid non-union, whether you're going to use vascularized bone graft or not, not everyone has access to an MRI with gadolinium. Have you got any intraoperative techniques that you use to judge whether the proximal pole is viable?
Yes, I mean, I don't use the MRI with gadolinium much. It is difficult to get hold of, even when you think you can get hold of it. Radiologists don't like doing it, and it's not that accurate either. So yes, I do always check the bleeding, punctate bleeding. So if I know I'm going to be grafting somebody, then I don't do that under Wallant generally, just because when you remove the graft from wherever it is in the body, it tends to bleed a lot. It's fine using Wallant if bones are already broken. But if you're breaking a bone under Wallant, then I find that it tends to bleed. But yes, so if I will, usually use a tourniquet and a regional block or a GA if I'm going to take the graft from the pelvis. And then once I've prepared the scaphoid and used the curette and removed the sclerotic bone at the fracture ends, I will then let the tourniquet down and have a look at the both edges to see if you've got punctate bleeding from either side, before deciding whether or not to vascularize my graft. I'm not the world's fastest surgeon, and to do a vascularized graft takes me a lot longer than a non-vascularized graft. So from list planning perspectives, it is nice to know in advance whether or not you think you're going to use a vascularized graft. Otherwise, my suggestion would be book the time, and if you happen to leave early, then you have a bit of fallow time in theatre rather than having to cancel someone else on the day. But yeah, if you can get the information before, then great.
Okay, thanks.
Thanks for that. Just to pick up an anonymous question, how do you decide when to acutely repair a scapholunate ligament, and how often do you do it? Scapholunate widening is sometimes seen without dizzy after foosh, fall onto outstretched hand. So this ties in a little bit with your talk, Jeremy. What would you say is the frequency of having to actually repair scapholunate ligament?
I have to say I don't repair them that often. Most patients that I've seen who have not got a dizzy but have widening on their scapholunate interval, when you x-ray their contralateral hand and wrist, they've got similar findings on the other side. And I think we have, I'm not sure we've mentioned it before, about the importance of x-raying your asymptomatic hand as well, because it's actually not that uncommon that you see people, I mean, usually it's younger people, often girls, who've got widening because they've just got constitutional laxity. So like anybody, if you're going to end up repairing the scapholunate ligament, you want to do it ASAP, because you actually then get some reasonable chunk of, I mean, it's never reasonable, is it? But it's as good a chunk as you can possibly have of the ligament. I would think if they've got wrist pain, they've had a fall, they've got a significant widening, and it's it's completely asymmetric to the other side, I think there's an argument for fixing them there and then with sort of wires to reinforce it. I have to say I'm quite a keen wire user. I think some of the questions were raised about whether or not you need to repair the lunotriquetral ligament in a perilunate, as to whether or not you need to wire them as well. My anxiety is always that if they do not as well as you might have hoped, then you've not done these things when you were there anyway. I tend to be a belt and braces type of person, so that would be my rationale, really. I suppose it probably is a little bit aggressive, but certainly if there's wrist asymmetry, an obvious widening, and they've got pain, I would fix it.
And I think Shakure Ismaili has got us a related question as to what's the, essentially I think the question is, what's the cutoff in terms of time that you take on an acute scapholunate ligament repair?
I think in my experience, it's been that if you are, anything beyond 3 or 4 weeks, frankly, that sort of stub of tissue that you can get some suture into it's getting more tenuous. Once again, I think I don't actually do that many of these. I don't do that many Brunelli type procedures, but I think your time limit is quite short. The books do talk about there being this reasonable bit of tissue that you can repair, but in my experience, it's not that brilliant even on day one. So the clock is ticking right from the start. I would say probably 3 or 4 weeks, and it's proving difficult. I don't know what everyone else thinks, but I think it's not that easy.
Nick, you have your hand up.
Yeah, I mean, after 6 weeks, that ligament isn't there anymore. For some reason it dissolves. I think it's because it's completely intra-articular and doesn't like synovial tissue. But yeah, 3 or 4 weeks, I've definitely done it. I have done a few at sort of 5, and by 6, don't tend to be there. So they need to have a pretty good history and a sore wrist that makes you want to do it, and it has to be within the amount of time. If you're not sure, as well as X-raying the other wrist, then you can send them for a dynamic set of X-rays, or if you have a mini fluoroscan in your clinic, then you can do it yourself. But I quite often send patients for a PA in full ulnar and radial deviation and a PA clenched fist to see if actually that widening worsens under load and under stress, and whether the scaphoid moves normally or not. And the reason, as I said also earlier, the natural history of scapholunate injuries is that they don't all develop a slack wrist, and it really depends on whether or not they develop a dizzy. And if they develop a dizzy, then what you're treating is the painful Kirk-Watson's effect, where the proximal pole of the scaphoid jumps over the dorsal radius. And if you do Kirk-Watson's and it's sore and it's within 6 weeks, then I'll explore it and fix it. But if Kirk-Watson's is negative and they're actually not that sore, or if the history is longer than 6 weeks, then I don't. I have explored 1 or 2 and actually found that it was intact and then just closed. But I've also been involved in medical legal cases that haven't been explored, and then they've developed slack wrist and you wish you had. I don't think it's a terribly big thing to do it. Again, I do these under Wallant. Sometimes it's not a terribly big thing to explore the back of the wrist and fix it with an anchor and put some wires in. And they tend to do much better if you repair them acutely, in my hands, than any sort of ligament reconstruction technique that I've tried, aka Brunelli or modified Brunellis.
Alex, do you have your hand up?
Yeah, I just wanted to make the point that you can do a diagnostic arthroscopy as well, in addition to everything else, and then make an intraoperative decision about whether to go on to fixing them. And the other thing with the scapholunate ligament ruptures, they can rupture in different ways. So some can be purely through the ligament, some can be an avulsion off the scaphoid or off the lunate, or even both. And so your repair technique is kind of pragmatic at the time of what you find intraoperatively and whether you're using bone anchors or not. And the other thing is, if there is a poor tissue quality there and you think that your repair is probably going to lead to disappointment, you can supplement it with other repairing techniques such as fiber tapes, etc., and anchors.
Yep.
One more question on the chat from Metwali Said Ahmed. In case of combined SLIL injury and scaphoid fracture, do you prefer proximal row carpectomy or reduction, repair, and fixation? Thoughts from the panel?
Well, I've done one of these so I was saying we don't see them that often. We don't do them that often. I've had one patient where it was clear that the ligament was ruptured and it was a scaphoid as well. And I went for it and I fixed it. I'm always anxious about doing a proximal carpectomy, at the outset. So I did I anchored the ligament and I fixed the scaphoid. And it's, to be fair, it's not a difficult operation. And actually, I think the patient did okay, actually. So that's what I would do.
I think, sorry, go on.
Yeah, I've had that situation as well, where I've had a scaphoid fracture and the ligament. I just did exactly what you did, just made the decision intraoperatively, and they do quite well as well.
I think this, it's an interesting point, because I think those scaphoid fractures in those scenarios are slightly different to what we see in other situations. I don't know what the panel think, but in terms of scaphoid fractures that have been fixed in the context of a perilunate injury, have you had many non-unions? I don't think it's that. I think it's less common in those situations. I think mainly because we're a bit more aggressive in terms of fixing the scaphoid, something to do with locking them down and being more stable as well, perhaps. But I think it's a big ask to do a proximal carpectomy straight off the bat with those combined ligamentous and scaphoid injuries.
I was going to make the point that because it's a significant perilunate transcaphoid injury, you are going to be immobilizing them for longer, and it's more stacked in the favor, and you're going to be more careful with them, which may be a reason why they don't tend to go onto a non-union.
I think the quoted rate for any other wrist injury, if you've got a scaphoid fracture as well, is that the rate of non-union for the scaphoid fracture will be much higher. Therefore, you should fix things. But yeah, I agree. In the ones that you catch early and you fix and repair everything that you need to, they tend to unite and do fairly well. And I agree with both the others, actually, that if something is repairable acutely, then I'd much prefer to do that. Whether it's I've screwed triquetrum fractures, repaired all sorts of ligaments everywhere, and I'll always give it a go at repairing their natural anatomy before heading to a salvage, and save that for plan B.
One last thing to just pick up that I think Jeremy touched on it earlier, in the context of perilunate injuries, repairing the lunotriquetral ligament. It sounds like, Jeremy, you're quite aggressive in terms of, if it's injured, you'd wire it and fix it. Is that fair to say? Do any of the panel have?
I'm belt and braces, really, because if I'm there anyway, for example, doing a carpal tunnel decompression, then I will fix what appears to be torn because I'm there anyway. And as I said, if you're there and you're repairing ligaments, the wiring is not difficult to do. I appreciate it can have morbidity with wiring things, but I just think if you're there anyway, there's to wire it at the same time. That's just I take your point. Actually, I saw those same presentations, Nick, you were talking about at FESH in last summer. I should have done the same thing as I did before, though.
So yeah, Nick, would you mind elaborating on that, please?
Oh yes, at the IFSSH conference in London, a couple of good talks, I think, by Mark Garcia Elias and Carlos Harris-Palou, saying that actually in those situations it's fine just to repair the dorsal scapholunate ligament and not have to repair the volar lunotriquetral ligament as well. I had been repairing both, so you have to do a dorsal and volar approach. And I think doing dorsal and volar approach, you are doomed to get a much stiffer wrist afterwards. But since then, I have done a couple where I've just repaired the dorsal scapholunate ligament. I've gone in dorsally. I use a joystick to correct the dizzy deformity, wire the scaphoid to the lunate, the scaphoid to the capitate to stop the flexion of the scaphoid. And then I also wire the triquetrum into the lunate and the triquetrum into the hamate. So I've sort of got wires like that on both sides, stabilizing the mid-carpal joint. And then I repair the scapholunate ligament. Everything is held in the right position. So I'm assuming that the lunotriquetral ligament might heal on its own because it's now in the correct position. even though you've only repaired the one ligament at the back. I leave my wires in for 2 months and I take them out under Welland, sometimes in clinic if I can feel the wire ends. And then I do some, again, my dynamic wrist x-rays, normally with a fluoroscopy, to see whether or not I get scaphoid widening. And so far I've been lucky and it's all been good.
Thank you very much. That was a great discussion. And on a closing note, I think I'd like to thank all the faculty on behalf of the organizing committee. That was an excellent session, and thank you very much for your contribution. And I'd also like to thank all the attendees for participating and all the interesting questions. And this webinar series from BSSH and BFIRST will continue, and we would let you know when the next session would be. And yeah, thank you very much and have a great weekend.